My name is Susanna Proudman and I'm a rheumatologist at the Royal Adelaide Hospital. I'm going to be talking about systemic sclerosis and inflammatory myopathies. First, systemic sclerosis or scleroderma. This is a relatively uncommon autoimmune inflammatory connective tissue disease with a variable prevalence ranging from 7 to nearly 500 per million and an incidence of 0.6 to 122 per million per year. It is more common in women with a peak age of onset between 40 to 60 years, although it can affect anybody of almost any age. And there are two main subsets which are defined by the extent of skin involvement. Limited cutaneous systemic sclerosis, which occurs 2 to 3 times more commonly than diffuse cutaneous systemic sclerosis. The etiology is unknown. There are rare familial cases and there have been GWAS studies which have demonstrated a range of genetic factors which may be associated with systemic sclerosis, but it's not exactly clear how they influence the etiology and onset of this disease. As in many autoimmune diseases, this includes the HLA-DR haplotypes and a number of other signaling molecules, including STAT4 and molecules associated with interferon cytokines, similar to the interferon signature of SLE. A number of environmental factors have been reported, including an exposure to silica, for example in miners, exposure to organic solvents, and an old-fashioned dry cleaning fluid, vinyl chloride, was associated with systemic sclerosis in previous years. Just a note that this talk will not discuss morphea, which is a form of localized scleroderma, which can occur anywhere on the body, may cause underlying deformity, particularly if it occurs during growth period in younger children, but is not associated with internal organ involvement, unlike systemic sclerosis. This is a heterogeneous multi-organ disease, which is characterized by 3 pathological pillars. Inflammation, which is primarily due to autoimmunity, both cellular and humoral, as evidenced by the autoantibodies such as the anti-centromere antibodies shown here, as well as a range of cytokines, including pro-fibrotic cytokines such as TGF-beta. Clinically, there may be synovitis, myositis, and in the early stages within the skin, sort of puffy fingers and edema. Vasculopathy is one of the very first features of this disease. Predominantly manifest as Raynaud's phenomenon, which commences as a reversible vasoconstriction in response to cold, but over time there is endothelial cell damage, capillary dropout, and aberrant vascular remodeling and angiogenesis, which can give rise to abnormal blood vessels, both in the nail fold capillaries and in the lining of the gut, such as gastric antral vascular ectasia. And ultimately ischemic changes, whether that be digital ulcers, loss of finger pulp, and acroosteolysis, and digital pitting scars. Ultimately, these changes culminate in interstitial fibrosis. In the skin, this is evident as scleroderma, or thickened, tight skin, which begins on the fingers and spreads proximally due to abnormal fibroblast production of type 1 collagen with accumulation of extracellular matrix proteins such as glycosaminoglycans. It's worth noting that the skin is abnormal histologically in all patients, even if it is apparently normal in the patients, for example, with limited disease. As well as the skin changes, fibrosis can occur in multiple organs, including in the lung, causing interstitial lung disease, in the wall of the gut, causing hypomotility and a range of consequences of reduced peristalsis. It may occur in the myocardium, in the blood vessels of the lung, causing pulmonary arterial hypertension, and in the renal arterioles, causing scleroderma renal crisis. The diffuse cutaneous subset has a different pattern of onset compared with the patients with limited disease, with a relatively short history of Raynaud's phenomenon, rapid onset changes leading to flexion contractures, leading to involvement of the trunk and the proximal limbs. In the early stages, tendon friction rubs are common, and this is a poor prognostic feature indicating that internal organ involvement is more likely, along with constitutional symptoms. There tends to be early onset internal organ involvement, for example, interstitial lung disease and renal crisis. The antibodies that tend to be associated with this subset are SCL-70 antibodies or anti-topoisomerase antibodies, which are associated with interstitial lung disease, anti-RNA polymerase antibodies, which tend to be associated with scleroderma renal crisis, and ANA antibodies with a nucleolar pattern. Limited cutaneous disease is more common and may occur much more slowly with skin involvement which is limited to the upper limbs and the face. It doesn't extend proximally to the elbows or onto the trunk. Calcinosis and telangiectasia are said to be more common in this form, although they do occur in the cutaneous subset as well. Esophageal dysmotility is very common in both subsets. Clinically significant interstitial lung disease is less frequent, and cardiac and renal disease are rare. Anti-centromere antibodies are more commonly found in patients with limited cutaneous scleroderma than SCL-70 antibodies. Pulmonary arterial hypertension occurs with a prevalence of approximately 10% in both subtypes. The natural history of these two subsets differs, with the onset of organ involvement and skin changes occurring much earlier, usually within a couple of years in the patients with diffuse disease, as demonstrated in this graph here, with the blue line showing organ involvement occurring very early, often within the first couple of years in those patients, whereas in the patients with limited disease, the rate of onset is much slower over several years and is far less prevalent. These are some characteristics of patients in the Australian scleroderma cohort study, which demonstrate the prevalence of some of these complications. Interstitial lung disease, for example, is more common in the patients with diffuse disease. Scleroderma renal crisis is more common in these patients as well, and this is likely to be associated with the anti-RNA polymerase III antibody, which is more common in this group of patients. Whereas you can see that the prevalence of pulmonary arterial hypertension and gut complications such as reflux and fecal incontinence is not significantly different between the two groups. This table summarises the more common antibodies found in systemic sclerosis. The first three tend to be mutually exclusive and certainly are the most common, being the SCL-70 centromere and RNA polymerase III antibodies. The approximate frequency in scleroderma is listed here, and the clinical associations I've already mentioned, including the more likely organ involvement. In addition to my earlier comments, the RNA polymerase III antibody is associated with more extensive skin involvement and malignancy occurring within 2 to 5 years of diagnosis. The other three antibodies occur reasonably frequently as well. They are not always tested for, such as the TH-T0 antibodies, which are quite rare and associated with PAH and worse prognosis. But the RNP antibody and the PMSCL antibodies are detected on the usual antibodies to extractable nuclear antigen test, and these occur in both subsets and do tend to be associated with patients with overlap features, for example with myositis in the case of PMSCL. This disease has the highest disease burden of all the autoimmune rheumatic diseases, particularly in terms of mortality and reduced life expectancy. Cardiopulmonary manifestations are the leading cause of death, both primary and secondary, and the quality of life in these patients is lower for both physical and mental component scores compared with other chronic diseases such as lung disease and heart disease. The cause of mortality has changed over time. In the early stages, scleroderma renal crisis was the most common cause of death. This was prior to the advent of ACE inhibitors, when almost all patients with significant renal involvement died within 1 year. Since ACE inhibitors became widely available, the survival is now 80% at 1 year. And in recent times, mortality has predominantly been due to both pulmonary fibrosis and pulmonary arterial hypertension. The general approach to management includes a comprehensive assessment of organ involvement, and this involves a detailed history and examination, as well as specialised tests as indicated by the symptoms. The therapy is often dependent on the need to provide symptom relief, for example in Raynaud's phenomenon and gastrointestinal involvement, although there are some organ-specific therapies, for example for interstitial lung disease, skin, digital ulcers and pulmonary arterial hypertension. Unfortunately, we do not yet have an overall disease-modifying therapy, although we do use a range of immunosuppressive therapies, vasodilators and antifibrotics, targeting each of the pathological features of this disease. Over time, it's important to monitor for new organ involvement, particularly in the first 5 years in the patients with diffuse disease, and for pulmonary arterial hypertension at any time in both groups. There are a range of international recommendations and guidelines which I would recommend reviewing. The EULAR recommendations provide the strength of recommendation and the evidence base for this, a range of treatment algorithms, or in the case of the Royal Free NHS Foundation Trust Scleroderma Study Group, guidelines, detailed algorithms for treatment of each of the main organ involvements. Turning first to skin thickening or scleroderma, which manifests as puffy fingers very often, leading to proximal progression of skin thickening, joint contractions that may be compounded by the presence of arthritis. This leads to reduced hand function, and there's a generalized change in appearance that may have an impact on body image, mood, contribute to social isolation, unemployment and loss of income. There are general measures which may be useful, including physiotherapy, occupational therapy and splinting for hand contractures, and social work and psychological therapy may be necessary. Interstitial lung disease is reasonably common, as I've already mentioned, but the pulmonary function can be abnormal if you look hard enough in about 70% of patients. The diagnosis is reasonably straightforward. Patients may report reduced exercise capacity. On a pulmonary function test may demonstrate a restrictive lung defect. Crackles may be evident on examination, particularly at the bases of the lungs, and a high-resolution CT scan usually shows characteristic features of scleroderma-related lung disease, which is more commonly non-specific interstitial pneumonitis than the usual interstitial pneumonitis, with the first being predominantly a generalized ground glass and fine fibrotic features being seen, and in terms of the latter, more peripheral reticular nodular opacities with honeycombing and traction bronchiectasis. The question is who and when to treat, because not all patients with interstitial lung disease progress, and there are many who do not have clinically significant lung disease, but within the diffuse groups, diffuse patients, this can be a significant problem requiring therapy and may lead to pulmonary arterial hypertension, which has the worst prognosis. It is likely that we will be able to better define high-risk phenotypes, and one group has defined that as being the patients with early diffuse scleroderma with the anti-SCL70 antibody or with signs of systemic inflammation. Another way is to look at the grades of interstitial lung disease on HRCT, and these images here demonstrate limited disease in the periphery of the at the bases, indeterminate where there's a little more fibrosis, and quite extensive involvement where you can see that it affects most of the lungs in cross-section and presumably at multiple levels. And this can be used fairly simply to stage the extent of interstitial lung disease with some minimal training. Reviewing all the slices on the HRCT can allow you to fairly easily define those who have less than and greater than 20% or limited or extensive disease, although there will always be some in whom it's difficult to determine the extent. And the pulmonary function test using the forced vital capacity may enable you to separate these into limited and extensive disease. And this is important because this is clearly associated with prognosis. Those patients with more extensive disease having worse survival, in this instance at 10 years, less than 40% of the patients being alive. And in addition to these already mentioned, there are a number of other factors predictive of clinically significant interstitial lung disease. or further progression. Those patients who are male, of African American descent, and a range of biomarkers listed there. Pulmonary function with FVC less than 70% or a baseline diffusing capacity of less than 55% is also associated with a worse prognosis, in addition to the HRCT extent of fibrosis. It's worth noting that in the majority of patients in whom the FVC declines to less than 55%, they mostly experience this in the first 5 years. And hence patients with early diffuse scleroderma with ILD should be monitored with spirometry and diffusing capacity every 3 to 4 months for 3 to 5 years after disease onset, then yearly. And one could argue that this should be done even in those patients without ILD to identify early onset. The pulmonary function tests probably are adequate for this purpose, and there's no advantage in serial HRCT scans if the PFTs are stable. This little algorithm allows us to look at this in a little bit more detail. If an HRCT is done at background and at baseline and there is no interstitial lung disease, close follow-up with pulmonary function tests every 4 to 6 months for 3 to 5 years, as I mentioned, is recommended. Clinically meaningful decline, which would trigger an HRCT to evaluate for interstitial lung disease, in FVC is defined as a decline of more than 10% of baseline, or more than 5% with a more than 15% relative decline in diffusing capacity, and really any new symptoms attributable to ILD should trigger further investigation. If interstitial lung disease is seen on HRCT, the next question is whether this is clinically significant or subclinical disease that may not need therapy. And in this group have defined clinically significant interstitial lung disease as firstly requiring ILD on HRCT at least. Only one of these parameters may be necessary, although often there's more than one. The FVC predicted or diffusing capacity less than the lower limit of normal, and or the clinically meaningful decline as described earlier. Desaturation on oximetry during 6-minute walk testing is an important sign of clinically significant exercise-induced hypoxemia, which needs to be treated, and of course symptoms. All variables need to be met to classify a patient as having subclinical ILD. So, for example, they should have only really minimal HRCT changes, normal FVC or diffusing capacity above the lower limit of normal, and no clinically significant change and no symptoms. But these patients, as mentioned before, would be closely followed up, and in those who had the high-risk phenotype, any interstitial lung disease may still trigger immunosuppressive therapy. Of course, there are some conservative measures for treating interstitial lung disease, including maximising therapy for reflux, quitting smoking, vaccinations, supplemental oxygen if indicated. First-line therapy is often mycophenolate, or if intolerant, mycophenolic acid, or oral or IV cyclophosphamide, followed by mycophenolate or azathioprine if disease is severe or progressive and unresponsive to mycophenolate. And these recommendations are based on the 2 scleroderma lung studies. The references are there, which demonstrated an improvement or at least a failure to decline in FVC in these 2 treatment arms. There are a range of other therapies which could be considered, including antifibrotics, nintedanib and perfenadone, other biologic agents such as rituximab or tocilizumab. Lung transplant is an option in a very small number of patients with minimal other features of scleroderma, particularly no evidence of serious reflux, and there is now interest in autologous stem cell transplant for a range of scleroderma manifestations. There has been a study recently published of nintedanib, a tyrosine kinase inhibitor, which has been found to be effective in idiopathic pulmonary fibrosis, as well as preclinical models of scleroderma. Relatively early patients with ILD were assigned to receive nintedanib or placebo, and the annual rate of decline in FVC was the primary endpoint. It's worth noting that about half the patients were already on mycophenolate. And the primary endpoint was indeed met. In panel A, the adjusted annual rate of fall in FVC in the nintedanib group in the darker blue was 41 millimetres less than the decline in FVC in the placebo group. So not a major achievement in terms of improvement in patient outcomes, and still not really clear whether this is clinically important, this difference in these patients. But as the primary endpoint was met, it is likely that we may be able to use this antifibrotic in the future for these patients. Those patients who have ILD but worsening respiratory symptoms need to be reinvestigated with pulmonary function tests and maybe a repeat HRCT and the therapy escalated. Of course, there are other reasons for having a restrictive lung disease or declining diffusing capacity, including neuromuscular dysfunction, perhaps due to myositis, restriction of the chest wall due to scleroderma, aspiration due to reflux, and general deconditioning due to a range of disease manifestations. And of course, pulmonary hypertension is another explanation for a fall in diffusing capacity and exercise tolerance. And there are now a number of screening tests which I'll now go on to discuss. The DETECT algorithm is available online as a calculator. It involves a number of clinical parameters and the echocardiogram. The transthoracic echo based on the tricuspid regurgent velocity of being greater than 3.2 milliseconds, which is approximately 40 millimeters of mercury systemic pulmonary artery pressure, systolic pulmonary artery pressure, or an increase in the FVC to diffusing capacity ratio with a twofold upper limit of normal increase in the NT-proBNP. If there's any concern about the possibility of pulmonary hypertension, patients should be referred to an expert centre. Mostly we consider pulmonary hypertension in these patients as being precapillary or pulmonary arterial hypertension, and this is due to the vasculopathy, similar to that occurs elsewhere in scleroderma, affecting the small pulmonary arterioles, leading to increased pulmonary vascular resistance, ultimately right heart failure and death. There's been a range of therapies in recent times which have improved survival, but mortality and morbidity remain high. And it's important to remember that the differential diagnosis of pulmonary hypertension in scleroderma includes more than PAH. There's also the WHO Group 2 pulmonary venous hypertension due to left heart disease, and as in the general population, this accounts for approximately 80% of pulmonary hypertension, even in the patients with scleroderma, and they usually have evidence of systolic or diastolic dysfunction, either clinically or on echocardiogram, due to myocardial involvement, and this is more common in older women with systemic hypertension or prior renal crisis. Of course, there is the group 3 hypoxemic interstitial lung disease, which we've already discussed. These patients have an increased prevalence of antiphospholipid antibodies and therefore theoretically at least at risk of chronic thromboembolic pulmonary hypertension. And there is a rare complication of cause of pulmonary hypertension being pulmonary veno-occlusive disease, which has a very poor prognosis, and patients respond poorly to PAH therapies. It's difficult to diagnose clinically other than at post-mortem, although there are some characteristic features on HRCT, including mediastinal lymphadenopathy and a mosaic appearance to the lung parenchyma. It is probably present to some degree in true pulmonary arterial hypertension. In other words, there may be involvement of the venules of the lungs as well as the arterioles in patients with scleroderma, and this may explain why their prognosis is worse than most patients with idiopathic pulmonary arterial hypertension. This schematic demonstrates where in the pulmonary vasculature the pathology occurs to give rise to each of these different types of pulmonary hypertension. So pulmonary arterial hypertension occurs at the arteriole, pulmonary veno-occlusive disease is at the venular end, Hypoxemic lung disease is due to destruction of the lung at multiple levels, so multiple regions in the lung, and involves multiple levels of the pulmonary vasculature from both the arterial to venular sides, and of course ETEF occurs in the early pre-arteriolar area, and pulmonary venous hypertension, left heart disease, occurs right out at the left atrium. Pulmonary hypertension must be diagnosed by a right heart catheter, the reason being that you can define what type of pulmonary hypertension there is, as well as prognosticate for the future outcomes. So the precapillary pulmonary hypertension occurring on the arteriolar side of the circulation accounts for most of the causes of pulmonary hypertension in scleroderma. The definition now includes an increase in pulmonary vascular resistance greater than 3 Wood units, and this is also the case in those patients who have both pre and post capillary pulmonary hypertension. This is not the case in those, however, who have left heart disease. In the precapillary pulmonary hypertension, pulmonary arterial hypertension is now defined on right heart catheter as a mean pulmonary artery pressure of greater than 20 millimeters of mercury. Up to date, it's been greater than or equal to 25 millimeters of mercury. This is not currently used in defining patients eligible for PBS-funded therapy in Australia, but it has now been defined that those with mean pulmonary artery pressure between 20 and 25 should not be considered normal, and at the very least should be monitored closely, and perhaps have the right heart catheter repeated in order to identify those who are eligible for therapy. And this is the other major feature is that the pulmonary artery wedge pressure should be less than 15 millimeters of mercury, indicating that there is no left heart disease. On the other hand, those with isolated post-capillary pulmonary hypertension or combined with pre-capillary pulmonary hypertension, the pulmonary artery wedge pressure will be greater than 15 millimeters of mercury. There are a range of risk factors for scleroderma PAH, both clinical and on pulmonary function tests and antibodies, but unfortunately none of them performs well in the individual patient. So screening is now recommended, and there's evidence that those patients who have screening have an improved survival compared with those who are identified through normal clinical care, as demonstrated in this French study after 8 years. The initial screening guidelines were based on echocardiogram and changes in the ventricles, as shown here, and this is dependent on the peak tricuspid regurgitation velocity. But unfortunately, this has its problems, as I'll show you in a moment. With the ASIG echo-based pulmonary arterial hypertension screening algorithm shown here, which is used by a number of centres around Australia, this is based on the echo and PFTs. So an estimated systolic pulmonary artery pressure of greater than or equal to 40 millimeters of mercury, or a fall in diffusing capacity of less than 50% would trigger a right heart catheter. But any fall in exercise capacity, signs of right heart failure, or echo signs of right heart strain should lead to a right heart catheter, irrespective of the estimated systolic pulmonary artery pressure or diffusing capacity, as these can be normal. In particular, the limitations of echocardiogram relate to the fact that the systolic pulmonary artery pressure may not be estimatable in up to 40% of patients due to an absent tricuspid regurgitant jet. And of course, there are costs in Australia associated with annual echocardiograms, and this may not be cost effective. And echo does not distinguish between the different types of pulmonary hypertension. So another approach to screening is the new screening algorithm developed by ASIG after initial baseline tests as indicated, pulmonary function tests with criteria as shown on this slide, and NT-proBNP as shown on this slide form the basis of the screening algorithm performed annually. And if one or both components are positive, this is considered a positive screen, and patients should be referred to right heart catheter, and hence is not entirely dependent on an echocardiogram, although this and other tests may be undertaken to define the cause of the positive screen or other causes of pulmonary arterial hypertension. If both tests are negative in this screening test, then it can simply be repeated at 6 to 12 monthly intervals. As expected, for a screening test, the negative positive predictive value is high, approaching 100%, although the positive predictive value will be lower, being a screening test only. With respect to therapy of systemic sclerosis, PAH, it's a little different from IPAH in the sense that it is a complex disease. Calcium channel blocker therapies are not effective, and vasodilator challenge is no longer performed at right heart catheter. The initial therapy is dependent on the severity, and I'll show you how this is determined shortly, as well as regular assessment using these criteria. The role of anticoagulation is unclear, and over time the goals have been moving towards returning functional class and hemodynamics to normal. But of course, in patients with scleroderma, there may be many causes of reduced exercise capacity. The EULAR guidelines for pharmacological treatment include an endothelin receptor antagonist or a PDE5 inhibitor or riociguat. Continuous IV epoprostenol should be considered for severe class 3 or 4 PAH, and other prostacyclins, although these are not generally available easily in Australia. And this is the risk stratification table, which shows the parameters and the cutoffs which define risk of 1-year mortality. The green panel being a low risk of less than 5% and high risk being greater than 10% in the red. And the aim is to keep the patients or bring the patients down into the low risk group. Not all these parameters are measured regularly, but clinical signs of heart failure, symptoms, functional class, 6-minute walk distance, imaging, and maybe repeat right heart catheter are generally recommended, and NT-proBNP levels, although they are not currently PBS listed for this indication, MBS listed for this indication. So the treatment algorithm includes initiation of therapy. The vasoreactive challenge is not performed. The therapy for high-risk patients is actually initial combination therapy, and also for intermediate-risk patients now, with consideration for lung transplantation, and ongoing assessment for risk stratification. And if patients do not return to low risk, then combination therapy or additional therapy should be considered. It is also worth assessing patients for iron deficiency. Those patients in this cohort who had a combination of iron deficiency and pulmonary hypertension demonstrated that those who had both problems had the worst prognosis compared with those with just pulmonary hypertension, and those who were iron deficient also without pulmonary hypertension also had a worse outcome compared with those who were not iron deficient. Scleroderma renal crisis is a rapidly progressive renal impairment that is characterised by moderate to severe hypertension, often coming on suddenly, with relatively normal urine sediment, but progressive renal failure. It occurs in 10 to 20% of patients with diffuse scleroderma, and there are a number of risk factors, including RNA polymerase III antibodies, tendon friction rubs. Triggers include corticosteroids, and hence we recommend using less than 15 milligrams per day in patients with scleroderma, particularly diffuse scleroderma. There are a number of clinical features which indicate the severe vasculopathy and hypertension that occurs sometimes in this condition. Treatment is essential, as untreated end-stage renal failure can occur within 1 to 2 months. The important component of treatment is effective and prompt blood pressure control with an ACE inhibitor. There are a number of other therapies as listed here, particularly in patients who have signs of severe disease, in whom more rapid vasodilators may be required. And there is an entity of normotensive scleroderma renal crisis for which the same therapy is indicated. And I show this approach to the management of scleroderma renal crisis, which is found in this current opinion in rheumatology manuscript for your reference, although I won't go this in detail. There are still patients who progress to end-stage renal disease, although dialysis is beneficial, and many patients will have improvement in renal function to the point where they're able to come off dialysis. Nonetheless, mortality is still high in the modern era. There has been some experience with renal transplantation, although there may be recurrence in a small number of those patients. This just demonstrates that permanent dialysis has a worse outcome than patients in whom dialysis is not required, or temporary dialysis is required, with the latter two groups having a very similar survival. Higher blood pressure at presentation has a better outcome, and ACE inhibitor treatment before the onset of scleroderma renal crisis has a worse outcome. Raynaud's phenomenon is a common problem in patients with scleroderma, and there are a range of non-pharmacological measures listed here, predominantly keeping warm and avoiding triggers. Initial first-line therapy is predominantly with dihydropyridine calcium channel blockers such as nifedipine. Second-line agents can include PDE5 inhibitors or topical nitrates, and if very severe, perhaps annual intravenous prostacyclin can be used, and there are some surgical options including sympathectomy and Botox injections. And these options are recommended in the EULAR guidelines as listed here. Digital ulcers include very similar therapy, but they may require careful, regular dressings to remove any dry, dead tissue and to allow healing. Infection and large vessel disease can be contributing factors and need to be addressed separately, and the EULAR recommendations for treatment are listed here. And in the case of severe digital ulcers, certainly IV iloprost and PDE5 inhibitors can be used. Bosentan can prevent new digital ulcers but not treat them. This digital ischemic change is a critical emergency that requires urgent admission, investigation to identify any contributing causes listed here, and IV prostacyclin, excluding infections and avoidance of surgical therapy unless there's significant necrotic tissue will improve outcomes. Gut involvement in scleroderma is very common. This affects the gut anywhere from the mouth to the anus. The oropharyngeal involvement is probably underestimated. It includes sicker symptoms and difficulty swallowing, and this contributes to aspiration into the lungs, as does gastroesophageal reflux, which affects 90% of patients. There are a range of investigations which can be undertaken to confirm the presence of reflux, although it's not indicated in every case unless dysphagia is a major problem. There's a range of therapies that could be tried, both conservative, including change in diet, avoiding triggers, proton pump inhibitors often in high doses, and prokinetic agents, although easily accessible, effective prokinetic agents is difficult in Australia. Surgical therapy is probably best avoided, and certainly remember the possibility of Barrett's esophagus and stricture and possibly secondary malignancy that requires further investigation. Small bowel involvement is also common, mostly causing problems with bloating, but there are some significant complications, including small intestinal bacterial overgrowth, which may cause weight loss and malnutrition, and interception and pneumatosis intestinalis, which are emergencies. I've listed here a couple of algorithms from the Royal Free, again not to go through the detail, but to highlight that these are all options which you might like to consider if managing these patients, both for abdominal pain and distension, diarrhea and constipation. Fecal incontinence is more common than estimated. Patients tend to underreport this and may occur in up to 30%, and it is partly due to reduced sensation, but also altered bowel habit. Constipation with overflow, diarrhea is an important cause of incontinence. So therapies to improve the stool and treat constipation, and also to augment the sphincter, as well as physiotherapy and behavioural measures may be useful. Occasionally surgical options are considered. And again, there are EULAR recommendations for therapy. As you can see, the strength of recommendation is poor, as this area is an area in sore need of further research. I mentioned autologous hematopoietic stem cell therapy here, as there's a lot of interest in this currently, and it is an option for patients with early progressive disease at risk of organ failure. The indications are still being clearly defined, but patients should be non-smokers and non-responsive to standard therapy, along with diffuse disease within the first 4 to 5 years, with mild to moderate organ involvement, or limited disease with progressive visceral involvement, such as significant interstitial lung disease. An extensive and invasive workup is indicated as listed here. These are the 3 randomized controlled trials which have been published in recent times. The most recent one being the Scott trial, which had a lower mortality. That was a problem with some of the earlier patients, particularly in the early stages after transplantation. It's worth noting that disease relapse does occur at later stage in up to a third of patients. The reason why many patients die is actually cardiac complications, and you can see that both scleroderma heart disease as well as therapy-related complications can contribute. Of course, without going through the detail, really any type of cardiac disease can occur in patients with scleroderma with varying prevalence and therapies. This slide just summarises the range of therapies which are in various stages of investigation in clinical trials in scleroderma, as we're slowly starting to see advances in therapeutic options. Turning to idiopathic inflammatory myopathies, there are broadly speaking 4 types: polymyositis, dermatomyositis, including amyopathic DM, inclusion body myositis, and immune-mediated necrotizing myopathy, which until fairly recently was classified with polymyositis. And of course, there is the myositis, which occurs as part of overlap syndromes, which has similarities predominantly with polymyositis. But they all generally share the features of proximal skeletal muscle weakness and evidence of immune-mediated muscle inflammation. They do have distinct clinical, serological and histopathological features. The incidence and prevalence of these diseases are shown here. You can see that these are also quite uncommon autoimmune diseases, with a prevalence of DM and PM of about 5 to 22 per 100,000. IBM is probably less common, although it is the most common acquired inflammatory myopathy in individuals over the age of 50. The DM and PM cases are more common in female patients, whereas the reverse is true for IBM, and these patients, latter patients, also tend to be older. There are a number of different characteristics in the pathogenesis of these different idiopathic inflammatory myopathies, and in general the mechanisms are unknown, but you can see them outlined in this table. In dermatomyositis, CD4 positive plasmacytoid dendritic cells under the influence of type 1 interferon and complement activation through anti-endothelial cell antibodies target capillaries, causing in some cases a form of vasculitis and inflammation around the myofibers of the muscle cells of the muscles in a perifascicular distribution and keratinocytes. This leads to perifascicular atrophy, and there in general is no myofiber invasion. The autoantibodies that seem to be characteristic of dermatomyositis are mentioned here, and there are others which I'll describe in more detail, and it's worth noting that malignancy seems to be linked to the pathogenesis of dermatomyositis. Polymyositis is similar to IBM in that there are also CD4 positive T cells, but also cytotoxic CD8 positive T cells, myeloid dendritic cells, also under the influence of type 1 interferon as part of an adaptive antigen-driven immune response. And this leads to inflammatory infiltrates which invade myofibers. There are fewer antibodies in IBM, and the pathological features here are nucleolar degeneration and rimmed vacuoles. PM similarly has diffuse muscle fibre injury throughout the fascicle and invasion of myofibers, and typically has prominent MHC class 1 expression on the myofibers. Necrotizing myopathy is relatively acellular with only a few macrophages, no invasion of myofibers, and the appearance of necrotic muscle fibers. The antibodies here are commonly signal recognition particle or SRP antibodies and anti-HMGCR autoantibodies, both with and without prior statin exposure. And there's an association with this entity and malignancy as well. I've just demonstrated some images here to show these characteristics in more detail. You can see in the dermatomyositis there are perifascicular mononuclear cells leading to perifascicular atrophy around this fascicle in the panel below in the DM column. In the PM column you can see lymphocytes invading a myofibril. In the IBM column you can see these vacuoles in the middle of the myofibers rimmed with basophilic granules, and in necrotizing myopathy you can see some degree of necrosis with sparse inflammatory infiltrate. Discussing the dermatomyositis and polymyositis entities first, these patients have symmetrical proximal muscle weakness in more than 90% of patients with polymyositis, and myalgias and muscle tenderness in 25 to 50%. Given the amyopathic entity in dermatomyositis, more patients have just the skin involvement in this condition than proximal muscle weakness. The weakness, though, tends to involve deltoid muscles, hip flexors and neck flexors. May also involve diaphragmatic and intercostal muscles, leading to hypoventilation, hypocapnic respiratory failure. And there may be weakness of the striated muscle of the upper one-third of the esophagus and or the oropharyngeal muscles, leading to dysphagia and aspiration. In DM, the rash precedes the muscle weakness in 40 to 50% of the patients, also contributing to a lower frequency of presentation with muscle weakness. In both entities, there may be involvement of the cardiac muscle, leading to myocarditis and increased risk of myocardial infarction. And interstitial lung disease occurs in at least 10% of both the polymyositis and dermatomyositis patients. ILD can also occur in patients without muscle involvement in DM. It can be a very severe form. It's rapidly progressive with a high mortality with antisynthetase antibodies and MDA5 as mentioned before. I've shown some images here of the dermatomyositis rash, including Gottron's papules on the extensor surfaces of MCP and PRP joints. Gottron signs are these papules on extensor surfaces of larger joints. There is this scleroderma in a photosensitive distribution leading to the shawl sign, the violaceous discoloration on the upper lids of the heliotrope rash around the eyes, and the periungual erythema and ragged cuticles with nail-fold abnormalities similar to those seen in scleroderma. There are also other changes of facial erythema, including the nasolabial folds in particular, the Holster sign, which is a rash over the upper thighs, serrasiform changes in the scalp, and in the juvenile dermatomyositis subset, calcinosis cutis can be very widespread and a significant clinical problem. There are some specific syndromes seen within dermatomyositis and polymyositis. Anthiosynthetase syndrome occurs in up to 30% of these patients with mechanics hands, constitutional symptoms, Raynaud's phenomenon, a non-erosive arthritis, as well as interstitial lung disease, and antibodies to the tRNA synthetase enzymes being characteristic features. The melanoma differentiation associated gene 5, MDA5 antibodies, are associated with an important clinical syndrome which is often associated with a high risk of interstitial lung disease with a rapidly progressive presentation with a high mortality. These patients have the skin changes, arthritis, and may be amyopathic. These may not come to see the rheumatologist until late, as there may not be any evidence of muscle involvement. There is another group of clinically amyopathic dermatomyositis with an increased risk of malignancy, which overlaps with this MDA5 group, as some of them have this antibody. Clearly, the laboratory findings include elevated muscle enzymes, both creatine kinase, transaminases, LDH and aldolase, although they can be normal. dermatomyositis in particular. They're usually at least 10 times the upper limit of normal, but the level may not correlate well with weakness. Indeed, the CK may even be normal. CK and B can be elevated in the absence of myocarditis, although an elevated troponin 1 suggests myocardial involvement. Antinuclear antibodies occur in 80% of patients. There are two sorts: myositis-specific antibodies found in 30 to 40%, and those that are associated antibodies that we see in other connective tissue diseases and therefore are more likely in overlap syndromes. I've listed these myositis-specific antibodies that include the RNA synthetases listed in the top row. But there are also a range of others listed below that which have important clinical associations. In addition to the ones I've already mentioned, anti-TIF1 gamma is associated with severe dermatomyositis and malignancy, as is anti-NXP2. Anti-SRP is associated with necrotizing myopathy, as mentioned previously. Amongst the anti-synthetase antibodies, there are further differences in terms of prevalence of within the anti-synthetase syndrome and the prevalence of interstitial lung disease, myositis, and other disease manifestations as listed. As you can see, that there are different prevalences of the MSA and MAA antibodies in the different forms of myositis. So in polymyositis, there are in fact not too many antibodies at all. IBM tends to also have few antibodies other than the one listed previously, which is not routinely tested in Australia. I've mentioned the antibodies in NAM, or this is necrotizing myopathy, which is a form of MSA. These are MSA antibodies, dermatomyositis MSA antibodies. And you can see in the overlap myositis, most of the myositis-associated antibodies are listed there, associated with other connective tissue diseases, although there are some MSAs as well, predominantly the anti-Jo1 synthetases, anti-synthetases. And in this paper, it demonstrated the fact that about 60% of patients have one or other of these antibodies. The myositis-specific autoantibodies very rarely coexist in one individual. We see there's very little overlap between all the small circles. The big circles in the middle, however, are the MAAs associated with connective tissue disease, and these often occur together in the same patient. Other investigations include EMG, which can allow you to distinguish myopathic weakness from a neuropathic disorder. The features are non-specific and it can be normal in 10% of patients. The MRI has been a useful addition to the investigations in this condition. We usually request MRI from the hip to the ankles, and this can demonstrate areas of muscle inflammation, although again it's somewhat non-specific. It is helpful for targeting the muscle biopsy. There are other investigations to consider for the complications of both dermatomyositis, polymyositis to a lesser extent, and necrotizing myopathy, particularly for malignancy, which is increased in DM in particular. You can see that there are a number of solid organ tumours which account for approximately 70% of the cancers in these patients, and they're usually found in the first 12 months after the diagnosis of myositis, and may mirror disease activity of the muscle disease. There are a number of risk factors, both on muscle biopsy, in terms of skin with necrosis or vasculitis, older age, and the presence of dysphagia, and the antibodies I've mentioned previously. There are some antibodies that in fact seem to be somewhat protective against malignancy amongst both the MSAs and the MAAs, and an age and sex appropriate screen for malignancies is recommended as listed there. Cardiac involvement should also be sought, starting with an echocardiogram and ECG, as well as pulmonary involvement and esophageal dysfunction if there is any swallowing difficulty. Therapy is generally grouped together for DM, PM and necrotizing myopathy, although responses may vary. Outcome can be predicted based on the type of myopathy, with dermatomyositis and overlap syndromes being more responsive to glucocorticoids. presence of MSA may give an indication of prognosis, with JO1 and SRP being associated with worse prognosis, and a better prognosis with MI2 and overlap syndromes. And the clinical features at presentation, including greater weakness, interstitial lung disease, dysphagia, respiratory muscle weakness, and cardiac involvement and cancer, tend to indicate a worse outcome. The therapy is predominantly empirical, as there have been very few, if any, randomized controlled trials to demonstrate benefit of one therapy over another. But in the main, these patients are treated with high-dose glucocorticoids tapering over 1 year, usually 1 milligram per kilogram per day up to 80 milligrams per day, with pulse methylprednisolone of 1,000 milligrams, not 10,000, on 3 consecutive days if severe. Steroid-sparing agents may be used, such as azathioprine or methotrexate in more severe disease, IVIG and rituximab, or even plasma exchange in severe disease with severe muscle weakness, dysphagia, and respiratory failure may be considered. Once therapy is underway, monitoring with CK, muscle power, and pulmonary function tests is recommended. There are, of course, other general measures which should be considered, including in the acute phase, monitoring respiratory function, taking measures to reduce aspiration, and over time enabling patients to undertake exercise appropriate to their level of muscle weakness, photoprotection if they have skin disease, and measures are taken to prevent osteoporosis and infection. Inclusion body myositis has a slightly different clinical presentation and trajectory. It presents with an insidious onset of asymmetric proximal leg weakness, often for up to 5 years, with weakness of distal finger flexor muscles in almost all patients. More muscle atrophy is identifiable clinically, and dysphagia is more common, probably due to cricopharyngeal muscle involvement in up to half the patients. The CK is not elevated to the same level, usually being less than 10 times the upper limit of normal. It's not as useful for monitoring disease, and there is generally no evidence of systemic inflammation. About 15% of patients will have another autoimmune disease, and these patients tend to be less responsive to immunosuppressive therapy. Nonetheless, a limited trial of glucocorticoids is usually provided. Thank you.